Texas Lutheran University.
Good morning. I want to welcome everybody to our Krost Symposium this morning and our lineup of speakers. My name is Marie Pies. I am the Assistant Registrar here at TLU, and I also work with the student veteran population. It is a great honor that I introduce all of you to our first speaker this morning. I listened to a presentation by Dr. Helmer several years ago, and he made such an impression on me. When Professor Kent asked about a speaker, he was the first to come to mind. Dr. Drew Helmer is an expert in post-deployment health, which is the impact of combat deployment on the health and well-being of military service members. Dr. Helmer obtained his medical degree at Columbia University College of Physicians and Surgeons and his Master's of Science in Health Policy and Management at the Columbia School of Public Health. Dr. Helmer is board certified in internal medicine and completed his residency at Baylor College of Medicine in Houston. From 2001 to 2007, he was the medical director at the War-Related Illness and Injury Study Center, also known as RISC, and a VA Health Services Research and Development Career Development Awardee while at the VA New Jersey Healthcare System. The RISC is one of 3 centers funded by the Veterans Administration to further the health and quality of life of veterans with deployment health concerns through research, education, and clinical care. During this time period, he also developed the basic structure for a national referral evaluation for veterans with multi-symptom illness and was engaged in research and education efforts. From 2007 to 2011, Dr. Helmer worked at the Michael E. DeBakery VA Medical Center in Houston, where he was the lead clinician for post-deployment health in Houston and for the South Central Veterans Integrated Service Network. He also was the Associate Director of Research for Prime Care and the Assistant Director of the Neurorehabilitation Neurons to Networks VA Rehabilitation Research and Development Traumatic Brain Injury Research Center of Excellence. That's a hard one to say, guys. He has been the director of the RISC at the VA New Jersey Health Care System since December of 2011 and an associate professor of medicine at Rutgers University, New Jersey Medical School. Throughout his career, Dr. Helmer has conducted research focused on several issues important to veterans, including chronic pain, exposure to concerns, depression, and suicidal ideation, mild TBI, and sexual health concerns. Dr. Helmer has published more than 40 peer-reviewed articles on these topics, including the book Sex After Service, a guide for military service members, veterans, and the people who love them. His extensive post-deployment clinical experience, research work, leadership abilities, and vision will ensure continued success in providing top-notch services directed towards improving the lives of combat veterans. Please join me in welcoming Dr. Drew Helmer to Texas Lutheran.
Yes, thank you very much for inviting me to this wonderful Krost Symposium. When I first heard about this event, I thought, wow, I wish my school had something like that. It's a really unique opportunity to talk about some issues that you maybe don't have the time to do in your normal life. It's also an honor to speak to the next generation. I think in my work, I mostly speak to other healthcare providers, professionals, people already in their careers, and it's really exciting to me to meet my future colleagues, and I hope that I can share some of my experiences and knowledge with you so that a couple years from now you'll be up here doing this sort of thing. So thank you for that opportunity. I would like to start by giving you a little perspective on why I'm here to talk about this. I did not serve in the military, and so why am I so focused in my career on military service members and veterans? I did have family in the military, and You know what, can I actually switch to the lapel? This is not quite the right height. Okay, is that coming through okay? Good. So I did have family in the military, lots of family in the military, and let me have a show of hands. How many of you are veterans in the audience? Okay, so a smattering. And how many of you have family members who are in the military? You see, this is the way it is in America. We have a few people who actually serve and put on the uniform, and then a lot of us who are there to support those people. And that's the way it was in my family. I did do general internal medicine. I went to school, went and did a medicine residency at Baylor College of Medicine. And then at the end of that, I realized that there was a career for me at the VA. I was interested in answering questions, and I went to do a fellowship program in primary care research. And from that moment on, I ended up kind of getting sucked into veterans' health issues, and in a good way. I found it a very important calling, and I've spent really almost 15 years of my career working to advance the health and wellness and function of veterans after deployment. A couple of landmark events in my mind really solidified this for me. Actually, my second day on the job in New Jersey in 2001 was September 11th. And from our hospital, you can see off in the distance, you can see Manhattan. And I showed up for work not realizing anything was going on, and around 9 o'clock in the morning, looked out my window and we're like, what's that smoke? And at that moment, day number 2 on the job, it makes you realize something new is happening here. There's been a change. And so that was part of what led me to commit to do my part for helping veterans and helping our country. I became a specialist. I'm both a primary care doc. I like to think of myself as a country doc, but I'm also a specialist in post-deployment health issues. And this is an area of great interest and importance to the VA and to our nation as a whole, I believe. There are certain things, and you're going to hear about this today, a couple of these things that only military service members experience, and we need to recognize those things and help them. And I just also wanted to touch on my role at the DeBakey VA Hospital in Houston, where I provided primary care services to recent combat veterans. And those were veterans who came back and were recognized for having serious injuries. They got blown up, they were missing limbs, they had burn injuries, significant burn injuries. Those were the people that I helped in my primary care practice. So I'm telling you all this because I wanted to provide a little bit of context of who I am and why I'm here to talk about this. And I hope that it will help you kind of understand the importance and absorb some of these concepts. But I also wanted to remind you that I have just one perspective on this, on the issues I'm going to be talking about, the invisible injuries of the brain, mind, and soul. There are many other perspectives and many much more first-hand experiences with these issues. And some of the people who have experienced those things are sitting in the audience with you or sitting in your classroom with you. And so I really hope you can take to heart some of what I have to say. I have a little disclaimer here. I'm talking for myself, not the government. So what am I talking about today? I'm hoping by the end of this talk that I have raised your awareness of veterans' health issues, particularly those of the brain. And I'm also hoping that not only am I raising your awareness, but I'm also increasing your appreciation or understanding of some of the context. And also perhaps offering you some guidance on how you can assist to make it better for everybody. So let's start with awareness. And you know what, I just realized something. Okay. I'm going to show you a few pictures and give you a second to see what's happening in the pictures. These are all pictures from the internet. This is actually a great series here. So who are veterans? Veterans are all of us. There's actually a legal definition. There's a definition of veteran that's enshrined in law. and it defines a veteran as somebody who has served in the U.S. military on active duty for 30 days or more. And there are some other certain aspects of that law that defines veterans. But in some ways, being a veteran is much more about self-identification. And I'm going to talk a little bit about military culture and how that might help to consolidate somebody's identification as a veteran. But I also have found it really interesting. I remember I sat down with a colleague who was a veteran and was working in the mayor's office in Houston to facilitate and enhance veteran services and the quality of life for veterans in Houston. And I asked him, I'm like, so are you a veteran? And he's like, well, yeah, I was in the Marines. And I said, no, I mean, do you think of yourself as a veteran? And he was about 2 years out of the Marine Corps. And he's like, no, I see what you're saying. He's like, I don't really see myself as a veteran. I see myself as a Marine. And I'm still in touch with this guy, and he's now at the point where he's actually starting to think of himself as a veteran. And so I've seen that evolution. I've seen the person separate from the military and come in and say, I'm not a veteran. I'm like, well, you're here in the VA clinic. Why do you mean you're not a veteran? So there's an element of that who am I self-identification. And along those lines, you can see that there are other identities that happen, and I think that series of pictures highlighted that as well. At the end of the day, veteran is a label kind of for convenience sake, and labels have pros and cons, but it's important to also, it's important to speak to people and recognize their perspective on themselves. But talking about veterans in general, in the US, we actually have more than 2 million people engaged in our military system. We have, according to the latest DoD statistics, 1.3 million active duty US military service members. Remind you the denominator, the population of the US overall is a little less than around 300 million people. So it's about 1/3 of 1% are active duty military people. In addition to that, there's a little bit more than 1 million people in the reserves and the National Guard. And so that gets you to a little bit more than 2 million people overall who currently serve in the military. Not a very large number. I think got about 150 people out there. So, we actually have we may have, well, actually that's veterans. But, there wouldn't be that many active duty people in a random sample this size. How about veterans? Anybody who has served in the military. There are about 23 million living veterans in the US, and I've highlighted that 9 million have been deployed to combat theaters as defined by Congress. Of course, we still have World War II veterans around. That was actually the largest deployment of living veterans, although those numbers are rapidly dwindling as people die. And then the other conflicts, Vietnam was the next really big one. We had about 6 million people deployed to Vietnam, many of whom are still alive. And then more recently, since 2001, we've deployed about 3 million, a little less than 3 million people to Afghanistan and the Persian Gulf region, Iraq, Kuwait, that part of the world. So in terms of recent combat veterans, we kind of think of them as about a 3 million number. So once again, that's about 1% of our population has been deployed in the last 15 years. This is just a depiction of the SEALs of the different branches of the military, Army, Navy, Air Force, and the Marines and the Coast Guard. Just to remind you that there are differences within the military, different cultures, different subcultures, different ways of identifying yourself, and trying to raise your awareness of those differences. This is a schematic of what I think of as the military life cycle, and I think a couple things to highlight. This is a fairly universal life cycle. I mean, it's not specific to any branch, and it kind of simplifies things. But of course, you have 18 or more years before you even join the military. It's a lot of time to grow and to develop. And of course, at this point in our history, it's a voluntary step to go from this phase to actually enlisting or engaging with the military. But then people generally go through a boot camp, intense training period, and then are living in garrison, not deployed, stateside, perhaps at a base overseas, but not in a combat theater. And then they may alternate and go be deployed, come home, be deployed, come home. In the last 10 to 15 years, we've actually seen many service members go through this mini cycle multiple times, and that has an impact. The more you're deployed, the more likely you are to have post-traumatic stress disorder, the more likely you are to be exposed to physical trauma and have a traumatic brain injury, the more likely you are to suffer from some of the other consequences and experiences of war. And then, of course, at some point, maybe 3, maybe 4, maybe 5 years, 20 years later, you actually leave the military and you separate and you go through this process of reintegration. And then, of course, depending on how long you've been in the military, you may have another 60, 70, 80 years of life living as, quote, a veteran. It's important to understand that that military experience could be quite brief in the overall scheme of somebody's life, but it could be very dramatic and life-altering. Of course, there's also, while that's the universal pattern of military deployment, there are other differences. We're seeing more diversity in our armed services, more women in leadership roles. We're seeing an increasingly openness around gay, lesbian, bisexual, and transgender issues. And we're seeing, once again, more families and more diverse populations within the military. And it's important to remember that that diversity then also colors what people experience and what they move forward with in terms of health consequences and other life consequences of military service and deployment. But at the end of the day, people join the military to become a warrior. That's the job. And I'm using this particular acronym, this battle mind acronym, because I'm going to come back to it later on. But there are certain skills, there's certain knowledge, there's certain attitudes and beliefs that enhance your ability to be a warrior. You have to be invincible. You have to be able to follow direction. You have to be able to give orders. You have to be able to handle a weapon or handle the tools of your trade in order to contribute to the mission. You have to master some of these other skill sets here in order to be successful and just to survive. That's what the military is about. It's about fighting a battle, completing a mission, about getting you and your buddies to where you need to be. So what do we need to appreciate about that? That's kind of background, military culture 101. Like I said, I offer one perspective on this, and I think we have many other perspectives even in this audience, and maybe we'll hear some of those perspectives at the comment and question period at the end of this presentation. But what do I take from that as a doctor, as somebody who's trying to help people after their deployment? Well, if you look at it, war is a noisy, dangerous, dirty, traumatic activity. And like any of those adjectives would imply, there's lots of room for harm and damage to an individual. Some of these things are kind of universal across any deployment. Some things are a little more specific to certain deployments based on where they are, the type of warfare, the type of fighting, the type of enemy. But certainly chronic musculoskeletal pain, damage to your joints, overuse of your joints and your muscles, that contributes to pain that can last quite a long time after deployment. Traumatic brain injury, we heard a great talk by Dr. Cantu and Mr. Nowinski last night about brain injury, and it came up at the end, what about military service members and veterans? We'll talk a little bit more about that today, but The physical, actually hitting your head versus a blast is an important distinction, but both can result in traumatic brain injury. People experience gastrointestinal symptoms after deployment, fatigue, just being worn out, tired. That often goes with sleep disruption, disturbance of sleep patterns, other issues that affect your sleep. Post-traumatic stress symptoms, the nightmares, we'll talk about that a little bit more too, depression. Respiratory, in the more recent conflicts, there's been a lot of concern about open burn pits and poor air quality in a number of places where our troops have been deployed, and how that might affect lung function and perhaps other aspects of health. Headache often goes along with traumatic brain injury, but can also be seen separate from that. Cognitive dysfunction, similar. Hearing loss. The rate of hearing loss in veterans enrolled in the VA system is huge. It's probably 60, 70%. And it's often worse on the right side. And many of us can pretty readily figure out why that is. If you're firing your weapon, you're going to have more ear damage on the right side. And yes, there's hearing protection, and probably when you go to a gun range, you use hearing protection, as you should. But when you're in a combat situation, you may not have that opportunity. Also, there's a lot of big equipment, and so hearing loss is one of the most common health conditions that happens after deployment and after military service more generally. And then there are the other things that kind of go along with deployment. And this is a list that we see in our tertiary referral center, but this is also a list that I saw in primary care. I can't tell you the number of times when I'd have a patient come in and say, yeah, that's all, we can talk about my pain, we can do all that, but I'm about to lose my truck. I'm about to lose my house. My wife's so mad at me that she's about to walk out on me. I just can't figure out how to pull this stuff together and make it happen. So a lot of the infrastructure that goes around an individual needs to be in place as well. So let's talk a little bit about the specific invisible wounds of war, and there are many more, of course, as I already mentioned, but injuries to the brain, injuries to the mind is one way of thinking of it, and injuries to the soul. So, what do I mean by this? Last night we had a great talk defining traumatic brain injury, and I'm not going to repeat the definitions. I think Dr. Cantu did that better than I can. But I like to think of traumatic brain injury as a structural damage to the brain. Talked about the axons breaking down, disintegration of the axons. There's actual, physical damage, destruction of neurons and the connections. That's what traumatic brain injury is. And like they said last night, you can't see it. If you opened up the skull and looked inside, it would be like, oh, everything looks like it's doing what it should do, or it appears like it should appear. So that's one aspect of an invisible injury. When I was thinking about this talk and coming up with the brain, mind, and soul paradigm, to me the mind is actually referring more to the function of the brain. And I think post-traumatic stress disorder kind of exemplifies how the brain may not function, not necessarily even because of damage, although the two seem to go together. We're learning more and more that this pattern that we see of symptoms and problems it's not clearly one or the other, and it's not merely this plus this. They seem to go together in a way that we don't fully understand. But if you think about the symptoms of PTSD, it's an abnormal reaction to a psychological trauma. And it consists of intrusive symptoms, so flashbacks, nightmares. It can consist of avoidance symptoms, so avoiding a trigger, something that reminds you of the traumatic event. And that may not be a direct reminder at all. It could be something very tangentially related. PTSD is also characterized by negative thoughts and mood alterations, negative mood, like feelings of I'm bad, feelings of I wish I could have done more to prevent that traumatic event or some of the consequences of that traumatic event. And it's also characterized by a loss of interest in fun activities. And then finally, there's the hyperarousal, the irritability, the quickness to anger, the short temper that can come with this, as well as hypervigilance, patrolling the property to make sure nobody's going to try to get you. Those are some of the symptoms of post-traumatic stress disorder. And I think our current understanding is that PTSD is a disorder not so much of structure or damage to the structure in the cells, as it is an abnormal pattern of connectivity. So it's like a learned process. You've kind of learned something the wrong way. You're tapping into different parts of the brains, maybe that fight or flight response a little too quickly, a little too easily. And so for me, that's getting at that concept of the mind. You've got your brain, you've got your damage from the traumatic brain injury, and now you have the mind in terms of how your brain is actually putting things together. I think the soul part of this talk really gets at some of the most challenging the biggest challenges of that reintegration. So if you think about being in the military and serving in the military, you have a purpose, you have a clear role, you have expectations that are set out. You know you're supposed to carry the radio, you know you're supposed to react a certain way when something happens. When you get out in the real world, here, school, work, family, there aren't clear rules. And you may or may not have a clear sense of what you're supposed to do. And so I like to think of the soul part of this as the big questions. Who am I? Why am I here? Those can be really difficult questions for anybody going through a transition. But if you think about the dramatic transition that people have between their military service and then when they separate and become a civilian, when they become a veteran, that's a particularly challenging and wide chasm for many people. Not for everybody. A lot of people can, hey, one day I'm over here working as a nurse in the military at SAMC, and the next day I'm just across the street working as a nurse in a different hospital, or perhaps even working as a civilian in the same organization. But for a lot of people, that transition is very hard and very challenging. And it also touches on some of the same things about, potentially can touch on some of the same things about survivor's guilt or moral injury. The idea that you've either seen or engaged in activities that are just so contrary to your fundamental beliefs that it becomes very hard for you to live with those memories and that experience. So that's really what I mean by the brain, the mind, and the soul. And at this point, I want to give you a particular example. So this is not the name has been changed to protect the identity, but this is not an atypical patient that I might have seen in my primary care practice, or even where I am right now at the War-Related Illness and Injury Study Center. So this is a depiction of Jason. Jason is coming to the clinic and he says, I'm a 23-year-old Army combat veteran. I returned from Iraq 12 months ago after a 13-month deployment as a combat medic in Mosul. I was exposed to more than a dozen improvised explosive devices, and I was told before my discharge that I have traumatic brain injury. Bright lights hurt my eyes. I have headaches, nausea, and tunnel vision almost every day, and pretty intense back pain that's only a little better with the hydrocodone I get from my military doc. I can't sleep. When I do, I have nightmares. I have a really short fuse, and I get these attacks about once a week where I can't breathe or even think straight. My wife told me that if I don't get some help, she's taking her 18-month-old son with her to live with a friend. I just lost my third job in 6 months. You know, I care, but I don't care. All I can think of is my buddy who died right next to me. I do want to sleep if I can do it peacefully. I drink a 6-pack of beer every night, and it puts me out for a while, so it's good for a while. It just doesn't last long enough. I live more than 40 minutes away from the medical center and have difficulty coming up with gas money to make it in. During my initial interview here, I told them it has gotten to the point where I don't really care what happens to me. I'm stuck where I'm at. This scenario, this vignette kind of exemplifies a lot of the challenges, maybe more than a fair share of the challenges that some of our veterans experience when they're separating from the military and trying to reintegrate. And this is a slide I borrowed from a colleague, and the point is that, can you imagine trying to manage all of those things? It's just overwhelming. And of course, these things, the structural damage to the brain, the damage to the mind in terms of the symptoms of post-traumatic stress, perhaps even that more metaphysical issue, the soul, they're not separate. And they're all interacting with each other and with some of these other things. The relationship with the wife, the relationship with the employer, the physical pain, the symptoms that maybe limit your ability to concentrate or to function properly. And of course, when you also think about the stage of life of many of the recently separated veterans, they're often young. They're your age. They're in their 20s. They're trying to get back to school. They're trying to establish careers. They're trying to establish families, get jobs. There's a lot to figure out, and when you're kind of coming at it with a lot of these issues, it can be very, very hard, if not impossible, to succeed. And of course, as I said earlier, we're now down at this part talking about the separation, reintegration. But this period of life goes on for a long, long time. You've got a long time ahead of you. And so depending on how well you do right here, you may have varying success for the next 40 years, 50 years. So it's really important that at this stage, at that point where people are separating from the military, trying to reintegrate into society, that we give them as much help as we can to get them on the right track. Just to highlight, some of the, and provide some, once again, a perspective, hopefully a better understanding. I showed you this. This is what makes you a good warrior, right? This is what people train. Usually you get kind of about your boot camp plus advanced training and then other specialist training. You train up and then you train just before deployment to really hone these skills. You spend a year of your life at a minimum mastering these skills, becoming the warrior. Then one day you come home and all of a sudden you have to turn all of this off because this is what it looks like back at home. To act that way, to practice those skills. Instead of having your tight-knit group of buddies that you literally depend on for your health and welfare and survival, you don't have those buddies. They're not there. They may be other parts of the country. And you may not trust the other people who are not those buddies. You trust your buddies. They're the people that are going to keep you alive. Other people, you don't maybe trust them as much. Accountability, doing what you're told, doing what you need to do, making sure it happens, can come across as controlling in the workplace. Targeted aggression, well, if you're in a combat situation and you need to demonstrate your power, your authority, sometimes physical aggression is necessary, that goes over very badly in a classroom, right? So that's a challenge. A lot of these other things, another one that I like to highlight because it's pretty easily perceived, especially when the Iraqi combatants were using a lot of improvised explosive devices and roadside bombs. Nobody in their right mind in the U.S. forces would drive a straight line on the right side of the road through Baghdad or on a convoy in Iraq. They'd be driving like this. They'd be accelerating, stopping, erratic stuff. Erratic driving was the way to go in order to stay alive and avoid the bombs. When you see people doing that on I-10, you call the Rangers and say, hey, we got a problem here. And so that's a pretty recognizable one as well. So the point is, you've got warriors who thrive in a combat setting. you take those same skills and that expertise and that the knowledge, and you put it in this context, and it's going to take some time to unlearn those things, change the focus, and become optimally functioning people here at home. I mentioned the concept of health, and I just want to reiterate the concept of health and function. I like to think of it as participation. These are all components of participating. You have to have your body structure. You have a certain body structure. You may be missing an arm. That means that your health is going to be a little different from somebody who isn't missing an arm. You have to find a way to compensate for that missing arm. You've got, maybe you have pain, maybe you have sleep issues, your body function is off, and so you have to find a way to compensate for that in order to optimally participate or function in society. And it's not about a disease, and this is the other thing that I've learned over the last 15 years. There are very few, I shouldn't say that, it sounds like I'm not a doctor when I say that, but there are very few, there are more symptoms that people experience that are not attributable to a certain disease or an exact pathophysiology. And I think it's really important to realize that sometimes you need to manage those symptoms and work with the person in order to optimize their health and function by managing those symptoms. And sometimes it's a little less important to think about, is this a particular diagnosis? And I think these invisible injuries of the brain, the invisible wounds, are the perfect example of that. At this point, I don't really care as much about whether it's traumatic brain injury or PTSD. I want to know, what are your strengths and what are your weaknesses? Let's use your strengths to compensate for your weaknesses and find a way to get you to your optimal health so that you can participate fully in the way you want to participate. So what can we do to help? I know Dr. Gorgons is going to talk some more about rehabilitation and neurorehabilitation, and so this is kind of an overview of how do you help somebody. Well, first of all, you have to look at the whole person. You know, a person is not a disease, or is not their disease. Somebody does, if they have diabetes, they are not just a diabetic. They have other things that go with them. And I think this is becoming more prevalent again, this biopsychosocial approach, acknowledging that you've got work and occupation, you've got social support, you've got financial things. A person has a whole basket full of things that affect their health and their function. Helping people, you need to individualize it. Everybody is different. Nobody's problems are the same. You can have, one person with memory and concentration problems. You can have another person with memory concentration problems. Completely different reasons that those things are going on. You need to actually talk to the person and understand what is going on with that person and find a plan that can help that individual. And with veterans, of course, we've got the diversity of veterans as exemplified by these pictures. Goal-oriented. I think, maybe most people have goals, and I would say that a lot of our veterans are very goal-oriented. A lot of military activity is, we've got a mission, we've got a goal to accomplish, we're going to go out and achieve this, and that continues after they separate from the military. That's the same thing in healthcare. One of the things that is just really important in helping a person in the clinic with you is to say, what do you want to get out of this? What do you see yourself doing? How do you want to improve your health? What's important to you? If you don't get the buy-in from the individual, I can write all the prescriptions in the world and nothing is going to happen unless that person actually wants to do what I can help them to do, or I have to help them do what they want to do. You need a team-based approach. I think when you think about the holistic nature of some of these problems, when you think about the individual aspects of these problems, you can realize that it's not one person, it's not one doctor, it's not one social worker, it's not one person who's going to fix everything. The veteran or any patient needs a team, the right team, the team with the right skills the team that's going to be in the right place at the right time. Where's spouse? Here's spouse. Okay? Spouse, parents. Those are the people who are on the team because they're around the patient. They're around the veteran more than I am. I'm lucky if I get to see, see my patients in the clinic twice a year, 3 times a year. You need a team of people who can actually be there when they need help. And along those lines, you need a community. I've only been here since yesterday afternoon, but let me tell you, I've been very impressed by the sense of community here at Texas Lutheran University. The VAST program just seems like an exemplary best practice. That's the Veterans and Society Together program. I thought it was just remarkable that they have their own lounge, and it's really important that this community has come together to support veterans with some of these injuries and just more generally speaking. And so what can you do? We want you. We want you to help, to assist with this. And I think your presence here today is the first step. For many of you, you're already helping in some ways. But think about what you can do to demonstrate your awareness, your appreciation, and perhaps even find ways to assist veterans as they reintegrate into society and take advantage of what Texas Lutheran has to offer in terms of education and a community to support them. And then I think I'd like to close by just talking a little bit about, bringing you back to Jason. I'd just think to yourself, if you saw Jason, what could you do to help him? What could you do to make it a happier ending, to put him on the right path so that he has a happier, healthier, more productive life? And I think that's it. So I think we'll open up for questions. Sure.
How much, you talked a lot about the battle mind and warrior mindset that's necessary for success when in the military, and how that can directly almost work against you when you kind of reintegrate and become a veteran. How much resistance do you see to, I guess, acknowledging maybe the amount or the depth of the problems that some of our veterans are facing because of that instilled kind of machismo or toughness mantra in the military, and how can we help kind of get over that?
So I'm not sure everybody could hear the question, so it was kind of, the one, I'm going to paraphrase here, but if there's a culture, if there's a battle mind, warrior mindset, how do we help to overcome some of the barriers that might put in place, whether it's kind of that machismo, self-reliance, I don't want to ask for help, I'm a veteran, I'm a survivor, I can do this on my own. It's a great question, it's a very challenging, there's no one answer, of course, but I think it is really important to just once again kind of be aware that that may be a factor, and that awareness alone can maybe help you put yourself in that person's shoes and understand where they're coming from. I've had a number of patients and friends who have told me after the fact, I'm just glad you picked up the phone, to be there when things looked really bad, and we see this over and over again, that perhaps because of that mindset, that individual, I can do it, self-reliance, I can do it myself sort of thing, people will actually push away their loved ones, and people will say, I don't need you, you're not following my rules, you're not doing what I think you need to do. They can end up being very alone, and that goes across many deployments. So we see that even in Vietnam veterans as they get older, maybe function pretty well after they came back from Vietnam, and as they get older, they start to lose their social support and even push people away until there's nobody left. And I think that's one of the most important things, is if you see a veteran struggling, to not take no for an answer, to make yourself available, to engage, certainly to not be afraid of a veteran. I think, some of the pictures I showed, the homeless veteran, there's some negative stereotypes out there that when you kind of get beyond that superficial appearance can really, you'll see something different. Any other questions? Then I'll just add one other thing. I'm not here talking as a government official or anybody, or representing any healthcare organization, but I do know there are lots of resources here, and maybe even in this particular part of the world, with San Antonio being such a military friendly city, that there may be more resources here than anywhere else for veterans and for people who want to help them. There are literally hundreds, if not thousands, of not-for-profit organizations that are out there trying to help veterans. And if you can find a good one doing something that you actually believe in and can support, that's one way to help as well. Dr. Squires.
Thank you, sir. Is this on?
Yeah.
For a wonderful, sensitive, kind, and physician talk. Would you comment on the relationship between your experience with veterans and other types of first responders, the police, the firefighters? Sometimes I worry about our nurses that are in the emergency room, and I mean, they're in a combat zone, and physicians that see this every day. Can you make an analogy as a physician to what you did there?
Sure. So I think there are two things. One is often military personnel go into those professions. So I believe the prevalence across the nation for former military being in the police force, for example, is around 30%, which is clearly disproportionate. When you think about less than 10% of America have served in the military. So there's that element that we're talking about the same people in some of the cases. And then I think the other thing to just remember is that you've got many of the same cultural aspects, some of the same machismo, self-reliance. I've got a job to do. I've got a very important job and purpose, and some of that same warrior mentality is present in, certainly in the police forces, but also maybe in the fire department, EMS, and in the emergency rooms. Certainly, I have more direct experience working in an emergency room, and you kind of get into that mindset in the emergency room. It is adaptive. It's when you have injured people and sick people coming into your emergency room, you have time limited. You know what you're supposed to do. You got to keep that person alive. You got to get them to that next phase of care, and you got to work together as a team. And you know who you can trust, and you've got some really important stuff to take care of. And so those same skill sets. Same skills are really critical, and then can also bleed into the rest of your life as well. Okay?
Thank you once again.
Thanks.
Students at TLU engage in high-impact educational experiences that include civic engagement, aesthetic expression, critical thinking, and a focus on intercultural knowledge in a community that welcomes the interplay of faith and reason.